I'm Carol Dahl. Natalie Ellerton is with us, Sherry and we have a wonderful guest speaker. We're going to save her introduction to the time, but I think you'll really enjoy Kim. By now, you are very familiar with our ground rules. Thanks. You have been an amazing group. Everybody gets on time. Don't forget to mute your phones. If you look at the top of your screen, there's a little button to the right of meeting. You want to turn that off. You've been a very collaborative group, so let us know when we open it up for dialogue. If you have a question, if you have a burning question and you don't seem to be able, there's no break, feel free to use the chat box. The Optum team monitors that, so we'll make questions get asked. Hopefully you've been enjoying the homework every session. I'm going to be asking for 2 volunteers to review their homework from session 3. So we'll be looking for 2 volunteers for that. You've been great at the Survey Monkey. We coordinate with AJ after every session to see what you've liked and what you haven't liked, and we try and take that under consideration and make changes. Anybody's got any questions? I'm here. Please feel free to use that email. Today, let's review what we're going to be doing today. We're going to give you a quick rundown and review what we did on session 3. We had the wonderful Derek Peterson with us going over all the analytics and use of data. We're going to be going through your homework. Hopefully you enjoyed figuring out, who you're missing and who you're going to pick and how you're going to structure it. And today, Natalie is going to guide us through various sessions, what we've done. So you figured out your cohort, you figured out what your needs are, you figured out the gaps, what you're going to do. How are you going to make that come alive? How are you going to build that neighborhood? How are you going to build that health neighborhood to support your clinical integration model and give you why you're doing it, your business rationale? How do you get everybody to work together? How do you structure it so it works? And then we've got our wonderful speaker, Kim, to give you a real live example. I think you're going to be impressed by the work that she's done, but make sure you ask her the time frame that she did it in. Change doesn't happen overnight. It takes time. And then we'll review session 5 homework. So that's the plan for today. So let's do a brief recap of our last session, session 3. Sherry led us off on that one and did a great job of helping us understand what's our clinical model. Who are the patients that we're caring for? Who are our members? What are their needs? And based on what can you offer as an entity? What do you do well? What do you need help doing? What are you capable of doing? What are you capable of getting started? Or you just can't get that done and there's gaps, and figuring out what partners you're going to need to help you fill those gaps. Trying to give you some structure for who you're going to pick as partners. And very, very important was we talked about making sure that everybody's goals were in alignment. Do you have the vision for getting to the same place, getting there the same way? A little variance is good, but do you have the leadership and the governance in place to make it happen? Geographic considerations. Where do your members live? Where are your providers located? Do you have access issues? Capacity. Can people get there? Are there panels open to accepting new members? How are you going to communicate and integrate information?
Hello?
Carol, we can't hear you.
Hello?
Carol?
I think Carol hung up. And I don't have web connection. I'm sending something to AJ.
Well, we can go on. I think I'll send her a pinger till she joins back. This is Sherry. So essentially, we talked through criteria for thinking about how to bring partners in. And then we also talked a little bit about the types of potential agreements that you might have.
And part of that was, the more risk that as an entity you're taking on, the more structured you want that agreement to be, to make sure that you're going to be able to garner the results that you need to be successful in value-based contracting. So from there, maybe we can talk a little bit about reviewing homework. And are there any volunteers who would like to talk about what you did?
Hi, this is Renee. I'm kind of happy to share because I feel like this is a real life experience, so it's very useful, this particular homework. So we're a behavioral health provider, and we are pursuing certified community behavior health care clinic status through the state of Oregon and through the federal government. And one of those requirements is to provide on-site primary care at 20 hours a week for each participating clinic. So we've been through a couple of different incarnations of this conversation, and I think initially when we start thinking about, partners, we want to find someone who has similar mission values as my agency, Cascadia, to make sure philosophically we're kind of on the same page. And then after we kind of have our list of organizations with similar values and mission statements, then we start looking at things like geography and what makes sense. For example, one of the things that we did is within our electronic medical record, we went through and had a report on all of the primary care assignments, so we can kind of see not only where people are being assigned, but where there are pockets or clusters within the clinic, which helps to drive who may be the best partner from a client perspective. If we see a large number of patients or individuals being served by a primary care practice that are also going to the community mental health center. So I think for us, those are kind of like the two big criteria in terms of, what do our clients' needs, what makes sense in terms of geography, and how's that going to work in terms of data exchange and technology and electronic medical records. But I feel pretty strongly that really the most important thing is finding a partner who is excited to work with you and who has similar goals and values. So because I think once you have those things, it's a lot easier to figure out any of the challenges and barriers that will inevitably kind of happen. And as we did this in past relationships, if we can, I'll go back to, our end goal is to best serve the clients in an integrated care setting. How are we going to do this? That stuff's all easy once you agree upon what the end point is.
So Renee, when you were doing that, did you have, how did you kind of codify the who would do what, and I mean, how did you had similar vision and goals, but how did you codify the actual day-to-day working?
Yeah, and it evolves over time, and I think what we started out with is certainly not what we ended with, but, I would kind of think of it in three different buckets. You have the behavioral health side, or behavior health functions or tasks, the primary care functions or tasks, and for me, those are pretty easy. It's kind of that gray area that's most challenging, and for us, that position would really kind of be around the care coordination. So we have one individual who, for example, may be employed by Cascadia, but is really doing the work for both agencies to help us get to what our goal is. So I think that's kind of where some of the trickiest stuff comes on is, what is it that we need to support the programming and to support the client and to support the infrastructure. So again, we kind of started with what made sense at the time, and then as we became more familiar with our partner, more familiar with our metrics and our services and what our goals are, then we made some adjustments to do that. But, it's definitely a work in progress, and I think it takes a good 6 to 12 months after you've maybe implemented that first evolution of the workflow to make sure that, to decide if it makes sense and if you want to keep moving or if it's time to go back and make some adjustments.
So did you have any kind of a legal agreement? I mean, you referenced process flows. Did you sit and map out processes together? How did
we did? Yeah, we're pretty fortunate in that my organization was awarded a primary and behavioral health care integration grant through SAMHSA for 4 years. So we knew we had 4 years working with this partner, and we had some very definite outcomes and goals and deliverables that we needed to provide. And we had about 3 months of planning before we had started providing the integrated care services. So it gave us a lot of time to talk about workflow and role definition. And in terms of like the relationship, we had a business associates agreement, and each organization billed for their own services and then received the revenue for their services. And then there was some additional funding that helped to subsidize the cost of the services through SAMHSA. So that kind of got us to the 4 years, and now we're moving forward doing integrated care with a different partner and, somewhat of a different model. And we're in the process of really kind of outlining these things, and there'll certainly be some differences between, that partnership and this partnership. But I think our previous partnership certainly gave us a good understanding of what kind of primary care culture in rural looks like. And it gave us a really good understanding of care coordination and some of the challenges that exist around the data sharing, data entry and, shared records technology and all that good stuff. So, depending upon the capacity and the resources of the agency and, who does what for who and when and what the goals are, it just kind of constantly changed and evolved for the first 2 years of the grant project that we had.
Okay. Did you ever contemplate a what happens if we don't get along scenario?
Yeah, I did, because there's probably 140 other organizations across the country that got the grant that we did, and I would say half, maybe roughly, just had some challenges kind of navigating the difference in the culture. For example, one of the biggest things that was different for me in the behavioral health setting is, the pace of primary care is very different than it is in community mental health. And there was some things I think very early on that may have been, maybe frustrating or a little concerning or annoying around how the other did it. But I think once we kind of had the conversations and understood, oh, you do it this way because, for me, if I know why we do something one way, it helps to make sense, even if it's not something that I agree with. And we've had disagreements. But we have the same end goal. So that's kind of what brought us back. That always brings us back to talking about how we're going to overcome the barriers. And frankly, we were obligated to be in this partnership for 4 years anyway. And, we're partners in the community, and we all, we get along anyway. But having that common vision or the common mission, I think, is really important, because it helps you acknowledge the fact that you have hurdles and challenges, and, we need to figure out how to get through them together so we can, reach whatever that end point is. And we did consider working with a different partner on a separate project. And the reason that didn't work out was more of a financial thing and not kind of a personality or a cultural thing.
Okay. So in this case, you had kind of the grant and the commitments made as part of the grant served as a bit of glue for you.
Yeah, it provided a lot of structure, but it didn't tell us how. We knew what we had to do. We just didn't know how we were going to do it. So the how was determined through a lot of talking and, compromising, and then referring back to the grant and what the grant requires.
Okay. All right. Thank you. That was great. Any questions for Renee? Okay. All right. Who wants to volunteer next?
I'll volunteer. This is Karen Williams, are in Atlanta, and we're a community health center. And this has been an ongoing, I guess, theme of partnering with various organizations. So the first question to identify partners are, I think as was said earlier, is common mission and common vision, but also looking at what are strengths and what are weaknesses that we have within our organization, such as what are the services that we provide that we're good at, and so then what is it that we're lacking for continuity of care for our patients. So then that helps us to look outward to see see who is able to meet those needs that we have in common, which is a client-patient quality of care and improved outcomes. So it was, and when I say it was fairly easy, in that the two partners that were selected were partners that we had worked with over the years, knew each other through various other forums and collaboration efforts that we had done together, ACOs that we were involved with together. So then it kind of just seemed like a natural fit. So then we looked at our hospital health system, Indigent Care Hospital, as well as our health department partnership, both of which carry the behavioral health arm so that we could integrate a more seamless area. And when I say seamless, how we would share with our EHR, share information, have integration meetings, that would work so that we're all benefiting from the communication that each of the partners are providing care with. So then we selected them based on those services that they offer that we didn't offer, but was definitely a need for the patient, and also selected the two partners based on common interests of meeting similar target populations, demographics, all of the threads that allowed us to link information. And throughout the process and over the years, it's just always, I have a mentor, a boss many years that coined the phrase co-opetition, where you share, but you still have something that's your own. So we had to get past that, and that takes a lot of time, and that's why I think our organization felt it was best to work with organizations that we were familiar with, that we had seen over the years that worked well, and there were no guards, no pretense, that it was basically about going the extra mile for the continuity of care. And so the model of integration is agreements that we have in place to share the information, the EHR. We even had to create bridges so that we could connect our EHR, which each one were on something different. So a platform was looked at so that we could share information, had to share documents for release of information, both from the organization entity as well as the patients and clients. So it was it was something that was already there in the backyard, but how do we bring it more, make a more cohesive partnership for the benefit of those that we're seeking to provide quality care to. So in that sense, I would say it's easy, but not easy. So even though you're familiar with over the years, there's still those nuts and bolts, those nuances that have to be looked at. Even the culture, work culture is very different. Work culture is very different from, I think, what's said before, from the type of services that are delivered, whether they're meeting with the care with a psychiatrist, or whether it's with a specialist for neurological testing, or whether it's the primary care provider doing a basic assessment with a PHQ-9. So it's bringing all those parts and pieces together that I think will make a successful partnership, and constantly tweaking over the long haul.
So we've heard common vision and goals, shared patience, shared commitment to making things better for our patients. Takes a long time to settle into some kind of a rhythm. Expect tweaks along the way. Any other themes from the homework as we think about ideal partners and who we selected, why, and then how we want to model out that integration? Okay. Has anyone on the call been part of creating a new legal entity so far? to take on shared risk or value-based contracting? Has anyone formally created a new legal structure?
This is Megan from HRH Chair. We created an IPA. I will say some of that groundwork and the development of the legal structure took place prior to my coming on board. So my knowledge of the process is not firsthand. I was not at the table for that, but it wasn't something that happened. Certainly not overnight. There was almost over a year of time invested in sort of developing that shared vision. And also bringing in some consulting resources and some legal assistance, both to, further refine that vision and put some pieces of a plan together for what the entity was going to do collectively, and also to formally establish the IPA legally. So there was some real dollars as well as time spent putting that together.
Okay, thank you. I may pick on you again, Megan. And you'll see why I'm going to probably pick on you in just a minute. So we have, as Carol said, we've been talking about who the population is we're going to serve, conducting analysis to see with whom we need to partner to meet patients' or members' needs, and then figuring out what kind of relationship we want with them. And this is a little bit more about figuring out some of the more, formal aspects of relationships, especially what seems to be coming in as a trend, creating extra legal entities to contract with multiple payers, or otherwise leverage the power of many in today's emerging value-based world. And this becomes more important, and the specificity of the relationships, the determination of who does what, the imperative around data sharing, as you go up that risk curve, the degree to which you will need to integrate, operations, data sharing, ongoing governance just becomes that much more extreme, especially as safety net providers, many of whom are in the primary care space. So we're going to talk about sort of what happens more up here: shared savings, shared risks, and global capitation. Not that we're expecting you to jump right in and go look for a contract with global cap. It's just to use this sort of more extreme circumstances to talk about some of the aspects of forming a new legal entity to manage that business. So typically we think of that as governance. Governance is one of 4, from our view, essential parts of functioning successfully in a value-based arrangement. You got to be able to do care management. Probably got to do some kind of a clinical or practice transformation, because if you're adding resources through care management, changing how you do things to accommodate new assessment tools, for example, or more formal care planning, probably need to figure out how you're going to free up space in the clinic, just from a efficiency, effectiveness capacity. Need an analytic infrastructure. We've heard both of our homework volunteers talk a little bit about data exchange, and that's an important part of ongoing governance and operational partnership. But we're going to delve a little bit deeper into that particular aspect of governance, and we'll talk more about active governance next session. This is just sort of establishing governance. And all of these 4 things are really needed for productive interactions at the clinic level. And we found all of these things necessary to reduce total cost of care and hit the other good triple aim +1 objectives of value-based care. In particular, governance is kind of the one that gets left behind. And there's often a lack of formality to it, which it's kind of interesting. And you heard the conversation earlier in the homework volunteers saying, well, we picked organizations that we had a history with, we were comfortable with them, we know them, we think we're somewhat similar. If you go into risk sharing and or global cap, you're going to have relationships with entities that you probably don't have a long history of relationship with. And so some of the artifacts that come out of that, once you've established that you've got some kind of a shared business vision, are things like legal and data sharing agreements. Renee, you talked about getting a BAA in place, the business associates agreement, so that you could exchange data. And depending on what data you're trying to exchange, there may be more additive constraints. There's sensitivities around. Yeah.
And I'll even throw in, we also, within that business associates agreement or MOU or whatever it was, we also allowed staff of one agency to the degree that it was needed to have access to the electronic medical record of the other agency as well. So just beyond data, but access to technology as well.
Cool. And, that sort of produces its own operational challenges. And we'll talk a little bit about data integration as a part of clinical information integration in a bit. But, there I would guess that if you're, each is looking in the other's EMR, you had to free up the time to train people, cross-train people, work out work processes, et cetera. And so all of that goes into legal and data sharing agreements. Then we found that it's also helpful to have, not just a board of new co or new entity or whatever, but a committee structure set up to help define policy and manage to related standards. And what I mean by that is, for example, when we set up the 10 FQs in Minnesota, we envisioned 4 formal committees of the board. One to focus on the financials, one to focus on clinical policy and agreed on care pathways, another to focus on access, and a 4th to focus on patient satisfaction. And those were all parts or all aspects of operating as an ACO. In addition to sort of helping the 10 get to know each other a little bit more quickly, it also helped involve people from across the clinics, the 10 clinics that were participating. And so it gave another venue for that kind of relationship building and cross-pollination of ideas and policy that ended up being sort of the soft side of governance. It's not a legal document. A legal document can't say you'll like each other, but, a committee structure that forces you to engage with your partners in a different way can do that. Another piece of this that's important is participation standards for all partners. And we found that there's a lot of thought usually that goes into, okay, who we want to participate and what they have to do, and they have to be willing to adopt certain clinical pathways and participate in these types of committees and deliver these sorts of surveys. Oftentimes, the piece that gets left behind in the excitement of starting something new is, well, what happens when things aren't going the way we want them to? And, we've structured our partnerships and our participation criteria and our reporting across our integrated entity in a way that helps clarify accountabilities. What happens when it becomes clear that one or more of the participants isn't living up to their commitments in this accountable model? So, participation standards for all partners should also consider, well, when things don't go quite according to plan, how do you address that? And is there actually exit criteria? And it sounds like kind of a downer when you're talking about establishing something new. But it actually ends up driving some pretty important conversations. It's very tempting to kick the can down the road. We just say don't. Try not to. And then, a lot goes into payer contracting support, doing financial modeling and analysis, setting up the performance reports, getting people to understand what's in them, and then tracking progress along the way. So those are all parts of governance that we think about. So last time, I think Sherry went through different types of agreements, and you talked about collaborations, compact, subcompact, or delegation. This is kind of partnerships, and we've got Megan here who has participated or felt the effects of being part of an IPA and the degree of formality that's required. I think, Megan, you mentioned that there actually probably had to be some kind of a capital call or something to kick in the money to put together legal and data sharing formal agreements. Is that what you've heard as well?
Yes, yeah. They each we have it's a 50-50 partnership for the IPA, and 50% of the IPA is owned by primary care delivery, and the other 50% is owned by behavioral health providers. And so, yes, each of that side of that 50-50 partnership had to contribute initial capital to start the entity. We had to have an operating agreement. We had to create provider participation agreements. We had to sign BAAs to allow data sharing to happen. So, yeah, there was quite a bit of that formalization of the relationship that had to be done.
Okay. So I think we're hearing a lot of sort of the term clinically integrated networks is popping up a lot in our world. Is it also in your world? Are you hearing clinically integrated networks a lot? Maybe not. Okay. Megan, you talked about one type, an independent physicians association. There are also PHOs, or physician health organizations. There are accountable care organizations. And accountable care organizations mean something different depending on who the payer is. You know, CMS has a definition of ACO for its ACO program, both Pioneer and NextGen. There are other states, state Medicaid programs, who talk about having ACOs, and sometimes they kind of go under pseudonyms. So, you know, accountable care organization, it's I think becoming a more formal term, but there's still sort of wiggliness around it versus an IPA is usually pretty clear, cut and dried, as is a PHO. Organized delivery system is probably another wiggly one. But the point of all of these is to be able to ensure collaboration without violation of antitrust. So they all have that in common. And the idea is to also leverage the power of the whole to get past hurdles. For example, you know, there may be investment barriers where one center or one practice can't necessarily afford or doesn't have the wherewithal to do it on their own, but 4 or 5 participating together can muster the investment needed to put things in place, legal things in place, like an organizational structure and a filing and writing bylaws and putting in place BAAs and non-disclosure agreements and other legal agreements. So I think we hear more and more of this in a lot of markets as a result of the Affordable Care Act, where clearly the policy intent across many different kinds of payers is to get providers to focus together, collaborate together. And they have needed vehicles to do that. So this is an area of, I think, health law that's emerging, evolving pretty fast as well. So the similarities are that, you know, all who sign on have to comply with contracting policies and procedures. So, I mean, you have to prove that you are integrated, and integrated as a network means that you abide by the same set of policies and procedures. There has to be evidence that you're monitoring work on common measures of care quality, safety, and cost effectiveness across each of the participants. So the more you can point to sort of shared or joint measurement frameworks, common reporting, which also, by the way, if you're doing common reporting, might imply some kind of data integration behind all of that. And then structure third-party contracts to incent provider attainment of established care, quality, safety, and effectiveness goals. Got to have the goals out there. Got to be able to demonstrate that the contracts you have with payers that you all adhere to are kind of bullseye on that triple aim. And then it helps, and regulators will expect to see more and more of shared infrastructure. And by infrastructure, we mean things like governance, data sharing, information systems, training, committees needed to set clinical policy and abide by clinical policy. And as time goes by, regulators look for more and more of those artifacts, and the legal entities that are helping them are looking for those sorts of artifacts as well. What are policies and procedures? How acceptable are they? What does health information technology architecture look like? What are some concrete ways in which they're sharing information? What does the committee structure look like in governance, for example? So all of these are things that, regardless of the flavor of clinically integrated network you need to be able to demonstrate from a legal standpoint to stay out of antitrust trouble. Just a little bit about technology. Information is critical to helping to coordinate care across different sites, especially as transitions occur. And there's some, practical reasons that data exchange is good. If you have all the information about a patient, as a clinician, you're probably going to make a better result about a better assessment and judgment about what it is they may need from a clinical standpoint. You're less likely to repeat tests and procedures if you know that they've been done and they've been done to standards that you trust and they've delivered results that you have access to. And coordination between people in care settings is one of the keys to helping to prevent things like readmissions or further ambulatory care sensitive ED visits, for example. So not just from a thin sort of legal perspective do you need to share information, but it's also about good patient care. And, unfortunately, current HIT, there are bits and pieces of being able to really integrate and share information and make shared decisions as you care for common patients. But the state of the art is still, I think, a long way behind what we all need it to be. EMRs don't necessarily talk to each other. They may be connected to health information exchanges. Each health information exchange differs in terms of what information is flowing through it and who's connected. And EMRs don't like to necessarily talk to each other. Very few of them are capable of ingesting information from external sources. And then there are kind of care management platforms that can sit on top of existing infrastructure. They may or may not ingest information from those source systems like claims or EMRs. And they may or may not have the right security access parameters to be able to really share across a wide network. So HIT, unfortunately, it's this really important component, and it's an area where we're lagging not only for sort of technical reasons, but also for political reasons. EMRs don't particularly want interoperability. Epic's answer is Epic everywhere. So lots of players have a piece in the puzzle, but we still have a lot of trouble really getting it together. IT is important also to be able to help demonstrate how you're driving administrative efficiencies. And that may be an area for shared services in an IPA or other consortium. And then you need to be able to demonstrate how you generate report cards on provider performance. So that's provider specific in your network cost and quality. Questions about IT and what you have to do to demonstrate integration? Okay, so here's what we've learned as we've helped consortiums of FQHCs get together. Hire a good lawyer who knows healthcare, who really understands the difference between what the Department of Justice is doing, what the Federal Trade Commission is doing, what their respective criteria for integration is, and then how to navigate data privacy, which, there are federal statutes and there are also local statutes. You need a good lawyer to help you. And having that good lawyer requires some money. So, be prepared for capital call, or maybe there are grants that you can submit. You may have to be a little bit creative about how you get together and afford the legal advice around steering clear of antitrust issues. That same legal advice can also guide you towards the right legal structure. Are you a PHO? Should you be an ACO? What does it mean in your particular context? And how does it translate then to a legal structure from a tax perspective? Are you a 501c3? Are you a 501c4? What's the difference? How do you make those decisions? And so another important lesson learned is really bringing your individual boards along, but before you get them too enmeshed in the detail, agreeing among yourselves as a collaborative or a clinically integrated network, what role you want those boards to play, because the business of the clinically integrated network is not necessarily the same as the business of your safety net practice. They're two different things. They relate, but have some careful thinking about an agreement among the participants on how you really want to engage your respective boards and what you need from your boards to make progress. Anticipate an exit strategy. We talked a little bit about this before. It's sort of maybe the equivalent is a prenuptial agreement. I don't know. It sort of seems like a downer to have to think about exiting when you're just getting started, but try not to defer that conversation for too long. And then be prepared for a lot of mundane time and effort spent just developing and putting in place strong documentation. We talked about business associate agreements, articles of incorporation, bylaws, participation agreements, operating agreements, contracts with payers. And then how do you make that accessible to the people who need to understand it across your clinical integrated network? So that was a high flyover of the basics of forming clinically integrated networks. Do we want to move on to our case studies? Or are there questions? Okay. How about we move on to our case study? We have Kim Reed with us today. She's a senior consultant in part of our Optum Consulting organization called Network Payment and Innovation. She's been with us for a couple of years, and she has worked with payers and providers to develop network-type frameworks, those organizations that will collectively work together in some kind of a formal structure to deliver care. She's got a lot of experience, she's military healthcare experience in TRICARE and Medicaid. She's worked for payers, and we're thrilled to have her here. She began her career as the executive director of an IPA. So Kim, take it away.
Thank you so much. I think this client situation that I'll share today is very pertinent to what you just went over, Natalie. So what we encountered here was a provider organization who really wanted to develop, or they had the paperwork, the formal structure, as Natalie just reviewed, in place. They wanted to build this network within 1 year. They, like many organizations, have limited resources regarding managing risk-based contracts, weren't really sure how to go about it and what to do. They didn't really have any particular provider partners in an actual network that was formalized. Of course, they had given thought, as many of you have already done, to who they might partner with, and folks who had those shared kind of collaboration issues and concerns, missions and visions, those sort of things. But they also didn't have any sort of payer or provider reimbursement model even developed. So some unique partnerships that were included, elements of this arrangement. They did have some consolidated vendors, which helped, and that could include EMR stuff. They had shared vision around their outcomes. They were in a multi-payer community kind of capacity. They had given some forethought into integration in government, and they definitely wanted an organization that was going to be benchmark driven. So their approach, if we can move to the next slide. Hello?
Are we there? This one?
Yeah, there we are. Thank you.
There we go.
So what they did is they actually hired consultants, and I think it was Megan speak to that too, up front to kind of help them figure out how to do this. So what they did in this case is they leveraged Optum's value-based contract experts to develop a strategic roadmap. They used Optum, the consulting team's actuary and analytics capabilities to model the downstream. And when we talk about downstream, we're talking about the contract that the clinically integrated network was going to have with their participating partners. So they needed some structure around that. And then the consulting team helped them to really develop all of their provider templates, whether that's the one that they, some real parameters with their payers, what those provider contract templates would look like, help them put in place provider manuals, engagement, network management processes, and really all of those details, I think that Natalie talked about how do you get to that integration really and truly sharing policies and procedures, outcomes, the safety, effectiveness, and so forth. And within this approach, it was really a significant transition for these independent physicians because their clinically integrated network was formed as an IPA. And so many of these kind of needed to realign their contracting across the care continuum, which required each practice to invest time and capital. So the group as a whole invested in the development of new capabilities. And one of the big things they did was the technology infrastructure. So they really did transformation consulting services. They made sure that they had some peer-to-peer collaboration for those to face any challenges that they would encounter. And they do happen. I mean, anytime you bring people together to collaborate, people have, whether it's a different approach or just kind of a different way to handle it, they can encounter some challenges. And so they really wanted a technology infrastructure that would help kind of with the algorithm, per se, of the clinical care. They wanted this tool to also help them with data analytics that would help them to understand when they're negotiating rates, whether it's with their own provider practices or reimbursement for their own provider practices or with payers, really where that makes sense. They had to have commitment. I think commitment is a big thing. They had to have commitment from each practice on data exchange regarding cost and quality. They had group representation and participation from each practice, again, in monthly performance review meetings, quarterly quality committee meetings, and a board governance meeting. They had to make sure they had compliance and establish quality and efficiency standards, so all part of that policy and documentation. Everyone in those provider agreements had to agree to adherence in the clinically integrated network guidelines. They had to agree to do some referrals back and forth, and they put in responsiveness times for those referrals and also for really just making sure they're documenting within their EMR system that was shared in this case. So agreeing to measurements of quality, patient satisfaction, cost metrics, and really those components are what ultimately determined the shared savings bonus participation. So a lot of work had to go into this and a lot of kind of thought ahead processes before anything can go live. If we want to talk about the timeline, the next slide really talks more about how long this took. So remember, this group wanted this done within 1 year. So what they did is they hired the consulting team, and the consulting team brought on the strategic leader or someone from clinical ops, analytics, and finance, and helped them really develop how that would work in a 12-month timeline. So what you see across the top are the number of months prior to go live. That's not the date the contract was signed with the health plan agreement or even the date that the contracts were signed with their partners, but really before membership started to flow into this organization. So they did have the consultants in place, and by 12 months prior, the technology analytics platform was developed and decided upon and put in place, and that really helped for defining the analytics data for selecting the practice partners, and ultimately was useful in helping them make the informed decisions about who those partners would be. And so sometimes I think you get into, hey, we get along with these folks, or these are who we share members with, but this group was really focused, remember, on outcomes and quality. And so they wanted to identify who their partners were that would help them from a high-performing network standpoint. So, and what freestanding organizations they would use for some care, because one of their goals was also to bring care out of a hospital setting and into one of their freestanding ambulatory centers, essentially. So they didn't hire their actual staff. They had the platform in place. They reviewed the data and selected providers based on really the quality that were providers based on cost and outcomes. So they began, by 11 months, they were developing those downstream templates, and so they issued contracts for the provider partners. And they didn't have a solid framework yet on how their shared savings would work because they hadn't negotiated the provider contract, or the payer contract, rather. So it was kind of some ambiguous language in that, but the partners had all agreed that that would be acceptable, knowing what they wanted as an outcome and as a result for this clinically integrated network. So about 9 months, which could be kind of late, candidly, they started negotiating this contract with the health plan for their IPA, essentially, for their clinically integrated network, which takes some time. So all of these processes keep coming. You keep refining as you go along. In about 6 months, they had finally formed that governance committee that said, okay, here's who the players are from each practice that are going to go to each of these specific meetings. Here's how we're going to work out issues if something comes up. So all of that infrastructure was put into place. Those folks also helped to finalize any details on the shared savings agreement for provider downstream agreements, as well as ultimately the health plan agreement that was signed 3 months prior to go live. So that might seem like a lot, but at the end of the day, it's really not, because you're trying to take a group of individual providers and get them geared up, trained for this new population, or maybe existing population, but just how you're going to treat them differently is going to come along. And as well, the health plan needs some time to make sure that their systems and infrastructures are set up to support the clinically integrated network. And then really only 1 month before go live, or these actual patients were in place, did they finalize those incentive details for the downstream provider contracts, the shared savings arrangement, and they started to do their own in-house hiring of staff that would take on the roles of the clinical director and the finance director and those sort of roles that they needed for their network just 1 month prior to incentives. And part of the reason for that, they really wanted to make sure that they had an agreement in place and that they knew where their revenue stream would come from going forward. So any questions on that piece? Okay. So let's go ahead and just share kind of how this worked out. Good news is that the client did meet their goals, and they were able to put that network in place in time. They did secure one health plan contract, as we talked about in the timeline there. I think they were very interested in working with some other payers in the community, but there was one particular payer in mind that they knew they wanted to work with and really help serve some population needs there. They implemented their operational infrastructure for managing the risk agreement and managing the provider network, and they did develop the full network of providers to meet the health plan requirements for the clinically integrated network. One thing to note here is this example, if you look back to Natalie's, is really more of a level 4. So this is a shared risk agreement within clinical integration, and it does have the shared savings component. So there was a lot of that coordinating as it demonstrated before. This group wanted to approach a health plan because they knew after all of the analytics and the data that they'd done that they really could provide a value and cost savings to the plan, which ultimately they could reap the rewards of, frankly. And they didn't want to give up those dollars in the long run. And they really wanted to care for their patients in a very specific way that was meaningful, they felt, to better health. There were some valuable lessons learned in this. I know we're getting close to time here, but I think the key for them was really they had that shared repository to effectively manage the entire population. That's really what this is about, is managing a population, not just the patients that are there today, but if you have a specific population, sometimes that's a way to think about how do we structure something, and they definitely did that. They avoided the critical mistakes of just having all providers in their network versus very critical selection of just those high-performing practices. And I think that's hard for a lot of practices when they put these clinically integrated networks together, because it's, you have those that you often refer to, those that you trust, those that you know, those that you maybe play golf with. I mean, whatever those reasons are, but when you're really building this and you're trying to do it in a way that is serving an entire population and you're trying to create a real value for a plan, what they did was chose really the high-performing practices. They tried to anticipate what data they would need from the health plan, and in this case, they did need data. They were fortunate because the health plan actually gave them the claims data from the varying provider practices within the group. So I think that proved to be very helpful for them. Certainly, it helped kind of upload their data repository of information initially. And also develop realistic and rational timeline for building a provider network. This group really thought that it could happen within 30 to 90 days, and that it doesn't happen. I mean, because of the reasons I talked about before, like you think everything's aligned, but when you get down to it and you're really talking about the nuts and bolts of how a processor works or how you would change maybe something clinically you do in a practice, or even the financial terms and your revenue for your individual practices, you find that there's some bumps and bubbles along the way, and you have to refine those things. You have to understand the impacts of having kind of upfront costs versus the resources. So you may not get the revenue you think from membership right away. Maybe you have to really think about that timeline and what members and what populations you're serving and when they come to you. So if you have a specialty clinically integrated network, for example, you're not going to have day one membership assigned to you versus the PCP practice where you may. So I think there's some variety and some variances in that to certainly give thought. And then ensure that you have a practice provider buy-in, and that's not just on timeline, right? It's on governance structure, it's on the care management program, it's on the reimbursement methodologies. It's really, I can't remember the term, I think Karen may have used, but it's really collaboration, cooperation, and you have to really gain efficiencies in how you drive towards those efforts. So that's kind of where this group was, and I think they've, they've since brought on other payer contracts, and going smoothly. And from a consulting perspective, we stepped out when their new staff came in, which was the plan all along, and I think it was good for the entire community.
Could you talk a little bit more about some of the, there's provider cost and quality, and the cost part is a little more straightforward. The quality part of that and how you look at practice pattern variation might be, more technologically challenging, more clinically challenging, and certainly more politically challenging. What are your thoughts about developing effectiveness measures?
Well, I think it depends on, so I think it depends on kind of the specialties and communities, right? Because there's benchmarks for care, which these groups use. This particular group used the specialty society benchmarks towards quality, so that helped in some aspects. But I think you've got to understand who you're contracting with and what you're serving this population for. Some of those challenges. it's a bit difficult to just give a broad brush answer to that, because quality is defined in a variety of ways. Obviously, if you're serving a population where HEDIS and STARS are a big deal, you want to make sure you're incorporating all of those elements into that care management program and into kind of your processes that you're building. But then again, like I said, this was benchmarked driven data, and so that's really how they selected their network, just to make sure that the ones that they brought in were already at those standards and already meeting those benchmarks.
You talked about they had wanted to contract with a couple different health plans, but they ended up working with one. I kind of
their goal initially was just the one. That was what they were striving for, but subsequently they have contracted with others.
Okay, got it.
Are there folks on the phone who have contracted or have put in place contracts with payers and can speak to the, Kim, you mentioned an important point, is anticipate what data you'll need from the health plan. We hear a lot of health plans say, well, just come to our portal. And then, if you've got 6 payers or health plans, then you've got 6 different portals to go to. Not all practices understand how to fluidly work with claims information. Are there experiences in the group where you've navigated multiple payers and their related data streams?
Hi, this is Renee. We're not quite there yet, but I'll share my experience. So again, we're kind of community mental health, and we really want to work on, we're providing more integrated care services, health and wellness and prevention, and we want to get paid for that, which would be great. However, I think the challenge that we're having is, it's the chicken or the egg. Is that are our payers going to pay us before they know we can deliver, or do we need to deliver before we can get paid? And the struggle that I've had is that, I'm quite happy to put together a project or a proposal or outline metrics or whatever it is, but what we're trying to do now is we think about, for example, focusing on diabetes screening and management in the outpatient setting. I know what metrics I want to have, and I know what success looks like to me, but where I struggle is getting feedback from the payers on the type of outcomes they want to see, so they'll be able to support us in the future. So at this point, because I'm not quite getting the structure or the information I need in terms of how to design the particular program, what I'm doing is I'm looking at the community health improvement plans and the coordinated care organization metrics that the coordinated care organizations need to report to Oregon on, and then Oregon in turn needs to report to the state. So I'm not getting a lot of information from them on what they want to see, but if I can go back a step and figure out what it is they need to report on and how they're getting paid, and then link that up to what I can do and support them in getting paid, then I find that people are much more open to having a conversation if I can show them how they can save a buck by paying me a buck.
We have a similar sort of challenge with a group of FQHCs newly forming who aspire to have contracts with multiple payers. We have the luxury in this case of the governmental entity being quite clear and quite circumspect about a set of quality indicators, and they're less quality and more utilization, which makes it a heck of a lot clearer and easier. I worry about what happens though when we come to, all right, we're either dishing up gains among our clinics, or we're reviewing performance and on clinical care delivered. How do we use information from multiple payers and clinical information to really establish credible performance reports and report cards? Has anyone experimented with pay for performance within your particular practice? or are you starting to think about incentive-based payments within your practices?
This is Laura from VNA in Illinois. We do have a couple of the MCOs that we have that pay for performance, a few identified quality indicators with that, and one of them actually has gone to a pay for quality ranking too with it. The challenge has been that they have identified in the last couple of months here that their patient or membership lists are not as accurate as they thought that they were, and so now we're not getting any of the reports generated out of it. So it goes back into what was said earlier, is that the data reports, the IT pieces, there's just some missing pieces within that there to be able to extract out what you're trying to accomplish with that. But yeah, we've started that this past year and a half.
Okay. Has anyone taken performance report down to the individual practitioner level within your clinics? Okay, sounds like maybe not yet. What we see in the market is, FQHCs in particular, sort of, I don't know about community mental health and other types of safety net organizations, but since you function with more, I don't know if it's a result of more mid-level practitioners, but attribution tends to be less at the individual practitioner level and more at the practice or clinic level, which then just sort of passes along an empanelment conundrum for you to figure out. So we don't see a lot of devolving sort of care pattern analysis and quality outcomes at the individual practitioner level yet in the safety net clinics we work with. So we're hoping that evolves at some point, and it's got to be balanced, I guess, with the counter tension that in many safety net clinics, staffing isn't necessarily abundant, and there's a war for talent there, and anything that would alienate your providers is a sort of takes on a different nuance because it's not easy to replace providers in that setting.
Natalie, this is Carol. I had experience when I was running provider offices, and one of my health plans gave me drill down information on provider performance on certain measures. So we were trying to figure out how to use that data, and we gave it to the individual practitioners so they had their own data. And then we had monthly physician meetings, provider meetings. At the time I didn't have any mid-levels, but at the time it was just physicians. And in our monthly meetings, we would, give the overview of where our performance was, our quality metrics, and we would kind of give an aggregate for the medical group. And then we would do, charts of physician 1, physician 2, physician 3. And they all wanted to know who the provider was that had the best score. And usually it was the provider who was very modest and didn't want to speak up. And then, later we would try and work with them, and we'd try and showcase that provider and have him or her at, one of the future meetings talk about, some of the things they did to get the performance and the outcomes that they did receive.
We had a similar phenomenon with our 10 clinics in Minnesota. Initially they started out wanting only blinded reports of performance. And then, within 6 months, they had started to say, well, who is this and which clinic is that? And why is the performance so variable? But I think it took probably about 1.5 years before they were completely willing to unmask and be transparent about really who was doing what. So trust over time gets built.
And this is Kim. I just add that certainly in the case study we did, they had the reporting down at the individual practitioner levels. And, you know, it does potentially create a challenge, but that was part of what they built into was that governance infrastructure to make sure that they went over those sort of things on a routine basis. And almost the forced trust kind of thing, like you just got to take a bite out of that apple, just got to go for it. And certainly my experience from an IPA perspective and plan and provider is exactly what you said. You start out often with blinded, and then you want to learn from one another. And what I found in my IPA experience was that the providers, mid-levels included, in those experiences were pretty competitive, and so they all wanted to have the best outcomes and results. So all good things at the end of the day.
I would agree with you, Kim. Very, very competitive. One of the things I had wanted to do, and I never got there, was, you know, we always are picking on the providers, but it's team, right? And it takes all of us to help with the members. And I always thought with, you know, all the emphasis on care coordination and looking for best practices and what are the nuances, you know, we're not there yet, but it would be interesting to try and get that level of detail with care coordinators, case managers, whoever your providers are, and look at, you know, who's the one that are getting successes and helping to close gaps in care and keeping people out of ERs and readmits and drilling that down at the care coordination level. I'm not aware of anybody who's doing that yet, but I think that's going to be something to come in the future, and rewarding performance at that level.
Yeah, and I think it goes hand in hand with what someone mentioned earlier, is that if you can, the gal from Morgan saying, you know, when she learns what the plans are needing, then she starts to speak their language, and all of a sudden she becomes, that organization becomes of higher value to a plan.
Okay. Questions, comments, concerns? Did we scare you? Did we bore you? What happened? All right, then. Homework time. So we've talked today about how to structure governance when you're going to choose and rely on kind of more formal collaboration, including some type of clinically integrated network. So let's assume that there are wonderful opportunities in your market driving you towards a clinically integrated network. And I guess, you know, we'd like you to consider, you know, we've heard examples, great examples of where you've partnered with entities that you know and trust over some history where you've been able to test that you have similar values. You know, is there anything in your market driving you towards something more radical where you might have to partner more formally with entities that you don't know necessarily as intimately as you have others in the past? And so, you know, if that were the case, you know, what's going on in your market? Are there efficiencies you can get by collaborating with other clinics? Do your health plans have significant quality-related withhold and or medical loss ratio problems compelling you to work together? What would that look like? And then if you're working with people you've never collaborated with, what do you think the implications are for a governance structure? And then, you know, think through some of it and describe the implications for the governance structure, but then also think about participation criteria. And this is a little bit deeper into, all right, you know we need each other. We're establishing some kind of a new organization. We know that has considerations for how we deal with each other on an ongoing basis. But if I really want you to participate in this clinically integrated network, what participation criteria, what am I going to look for that's most important? And consider it in the context of your market dynamics. For example, Renee, you brought up that you know, that the CCOs have certain quality-related targets. Whoops, oh dear. A little scratch there. Oops. Is everyone else experiencing static? Is it okay?
Oh, gone now.
It's fine.
Gonna? Okay. If, for example, your MCOs, payers, or CCOs have a withhold tied to quality on the diabetes 5, that might be a good thing to know, as you pointed out, Renee, how your payers are incentivized, and then you might look to partners on how they're doing with diabetes care, for example. Or if you know that lack of dental capacity drives a lot of emergency department visits, you might want to partner with dental practices, but what would be the most important participation criteria for them in your clinically integrated network? Does that make sense for an assignment?
Yes, it does.
Okay.
Yes, it makes sense.
Questions, concerns, again, don't spend more than an hour on this. Brainstorm in your individual teams, maybe. If you get stuck, let us know. We're happy to brainstorm with you. The exercise is really just to look at, are there factors in your market driving interest in feasibility of a clinically integrated network? And then how would you think about governing that? And then specifically, what participation, what kind of commitments are you looking from other entities that you don't know so well that might participate in your clinically integrated network? What's most important to you? Sound okay?
Sounds good. Sounds perfect. Sounds good.
Hey, Natalie, before we hang up, 2 last things. Don't forget, we really appreciate your feedback. Please complete the Survey Monkey evaluation form. And just to throw it out there, our next session is scheduled for Tuesday, November 15th. That's our 5th session. We have a really great guest speaker lined up, and the feedback you've given us is you really enjoy our content experts. However, we have a conflict with the date for that speaker. So AJ, I think, will be reaching out to you. We are either going to keep it the 15th or possibly reschedule to the 22nd or the 29th. So AJ will be talking with your folks, the team leads, to see if that's a possibility for you all. Right, AJ?
Yep, I'll be following up with an email based on what happened in the session today, plus with that information, probably tomorrow. So please be on the lookout for that.
Terrific. Okay. Thanks, everybody.
Yeah, thanks.